Afternoon. I'm Dr. Brian Boville, Pediatric Intensivist, Medical Director of ECMO at Helen DeVos Children's Hospital and of Blood Management, and I'm here to talk to you today about driving change with data. I want to thank the VPS organizers for inviting me to this virtual conference. I don't have any disclosures. A little bit about the hospital where I come from. Helen DeVos Children's Hospital in Grand Rapids, Michigan is a tertiary care center providing ECMO and all kinds of support. The only thing it doesn't do is cardiac transplant. It has approximately 1,500 to 1,700 admissions per year pre-COVID. Now it's, as you all know, that data has gone up and down. Today we're going to talk about one example I have of using VPS and hospital data to affect change, as well as discuss some of the barriers to that change that we have and still have. And as a new dog owner, anytime I can include a funny dog cartoon from Gary Larson, I'll try to do that as well. So let's talk a little bit about the practice of independent double check. Nurses have been independently double checking medications for over 15 years, and I want to say thank you to Karen Steenland and Leah Gronowski who have provided me some of these slides. Independent double checking was adopted on a sensibility basis. It adds a layer of defense, and since then, besides independent double checking, we've also added things like smart pumps, EMR advancements, dedicated pharmacy preparation, CPOE, and barcode scanning, all which have contributed to the safety of medication delivery. Now, back in May 2019, we took a different approach and decided to use some of our systems engineering colleagues to help us analyze how does independent double check work, so we could try to improve it because we were still having medical errors. And we ended up taking that data and going a very different way. But what it started as was a collection of things that you do in a human-centered work system analysis, and that includes semi-structured interview, observation, policy and protocol and standard work review, technology review, so looking at our EPIC and our MAR, a nursing literature review, and a human factors and resilience engineering literature review as well. So looking at independent double checks and looking at the barriers, which this slide shows, you see that there are a lot of things that affect independent double checks. So the size of the bubbles on the right are basically the size of the impact. And this includes things like workspace, culture, as we all know, policies, complication and non-standardization. And then you get some kind of new things that really surprised us. Things that like the redundancy principle violation, social loafing and diffusion of responsibility, and an efficiency thoroughness trade-off that goes through people's minds and their workday as they do things. So this was fascinating to us and took us in a direction that we didn't know we were going to be going. And then we looked at the Institute for Safe Medical Practices, what they say and their evidence, and we reviewed that. And we were surprised by the poor quality of some of their articles that are their foundation, as well as the questionable conclusions that basically state that they are very hard to do, these independent double checks, and that an organization should decide whether or not they should use them or abandon them in favor of other interventions. And so they kind of really sit on the fence. And so that made us think, do we need to do them? So we also looked at time studies, trying to figure out how much time we're using for this practice, and found that between 5 and 30 hours, with an average of 10 hours per day, were being used in our unit doing independent double checks. We found that 42% of nurses favored independent double checks and 58% preferred single checks, which kind of put us at a point of equipoise. So interestingly, more and more literature is starting to question the independent double check and its effectiveness. This mounting evidence has shown that there is an impact on work environment and probably an inadvertent impact on mental processing and the independency of the double check. So one of the things we also see is that the newspapers are catching on to these medical errors, and unfortunately we see that these medical errors are being distributed all over. And medication errors to me are very impactful because one of our transport nurses in the Northwest, when I worked out in Tacoma, She unfortunately was the ultimate second victim, and she felt so horrible about the medication error, and she worked up in Seattle and I was down in Tacoma, that she ended up committing suicide 2 years after a medication error on a helicopter where she was part of. And so I look at this very personally and think of this not just as for our patients, this is for our staff who, when these errors occur, can be quite impactful. So based on all this, we decided, can we make the conclusion that independent double check are a good idea and a sound practice to prevent medication errors? So, these were based on a couple of things. So the redundancy principle really is that, out of technical engineering systems, this was kind of born. And it's the question of one computer checking another computer, for example. And is that truly independent? And we really said that isn't independent. There is interaction. So it doesn't provide that independence and that double check that we really need. And we also said social loafing is there, which is basically you want to confirm someone else's conclusion because that is more socially acceptable, and that's also the other person wants you to confirm it because that takes some responsibility off them. And so these two things give you such a bias that maybe the person won't will not negatively interact or not confirm the actual results you're giving. So these efforts, I guess, in a sort of work system analysis are called social loafing and diffusion responsible. And then the other thing that was really big was we found that there's a human nature with good intent to try to be both efficient and accurate, and that nature is really, again, biasing the ability of the people to say, no, this isn't right, and they want to move forward with getting the work done. And so when we look at all that, we said we don't think that independent double check is a construct that always has to be done in our ICU. So we went with a single checking pilot and decided we're going to do, the ultimate PDSA. We're going to try this, look at the data, and see if it works. So we did this in the middle of COVID, and we spent a lot of time training, talking about it, and obviously measuring, so we had a baseline, so we knew if there's a change. Obviously, this made our administration very nervous, but we were able to move forward with this. So as you can see on the right, there's kind of how we train people about removing things like our dual sign-off. We spent a lot of time talking about nursing attitudes. And then we looked at how much does this impact the time pre and post. So results, what everybody wants to know, right? Well, first of all, I'd say the pure number of medication administrations. Wow, my nursing colleagues, you guys rock. I mean, 200,000 medication administrations. That's just blows my mind. That's what we ended up measuring in both groups. Of these, 1,200 qualified for independent double check. Again, this includes concentrated electrolytes and other high-risk medications. For the purpose of the study, we still did independent double checks on TPN and on chemotherapy. We couldn't quite justify not doing on those during the trial. We had 2 medication errors in the pre-period as well as in the study period. Giving us a rate when you look at for that was almost the exact same, and then we looked at time spent administering independent double check medications and hours. As you can see, we had an 80% decrease. And then we looked at the cost of administering these medications, which my slide may cover up, but that was an 80% decrease of savings of about $60,000 just in the 1 year we had. So, and then let's look at the outcome metrics. So pre-intervention, we were really at equipoise. And interesting, post-intervention, all of a sudden we found a huge change in surveys towards our nurses about about independent double checks, and a huge number of them that were really fine with single checking medications. And we found that the nurses were really changing from their buddies being their colleagues to leveraging the technology. That was one of the things that we found, that we still barcode scan and do all those sort of things, and that was really done with a greater attention to detail, and we found that became their buddy rather than the person. And when you look at it, so we then looked at, was there statistical significance of this change? And guess what? You could probably tell from the numbers, but I always, the stats do support that there was no statistical difference in medication error rate in the pre and post intervention rate. So this is where this is the USS Gerald Ford, which for those of you who don't know, Grand Rapids, Gerald Ford is our one of our presidents that came from Grand Rapids. And I usually show a video here of but I couldn't get it to work due to technological limitations of me. That of the aircraft carrier heading towards the Lighthouse and telling the Lighthouse it needs to move until it realizes it's a lighthouse. And that's kind of how we feel, given that we found this data, and obviously our administration is going to support, right? And we're going to move forward. Well, our administration, that's why I have a red slide, really came to the conclusion that while this is a great idea, they're too nervous, because the standard of care, in their opinion, is the use of independent double check. So what do we have to do next? Well, we have to publish the data. We need to get other centers to try to publish it, and we need to look at the VPS data, and we need to link and make sure our outcomes are the same. So what are our outcomes from VPS? And for VPS, we looked at a couple things. We looked at our length of stay, our age, weight, sex, our diagnosis by star category, our PRISM score, our PICU mortality ratio, and hospital length of stay. And we're hoping that some of you can join us with this. Now, again, we're going to have to ask you guys to do a little more work with either time studies, and we're just in the beginning of how are we going to do this at multiple centers. But here's a little bit of good news. So just a nibble. Really, this is hot off the presses. I literally pulled this on, I think, last Thursday, and then analyzed it on Friday, and that our PICU survival is exactly the same pre-independent double check, and post going to single check. No change with a p-value of 0.37, and obviously you can tell by those numbers. Now, this is a lower number, and this is part of I think the COVID effect. We saw that we had a lot less patients during our time. So that's something that we're going to hopefully try to extend, even though unfortunately, our administration has asked us to go back to double checking despite the data in 2022. So I want to say thank you. My time is almost over. Huge shout out to Leah Kowinski, and Karen Steenland for their tireless efforts on medication safety, as well as the Wendy Winger supporting this, and Robert Fitzgerald. For those of you who knew Wendy, I just would like to pass on that she unfortunately passed away from breast cancer this last year. And so this is kind of one of her legacies she's leaving us. If you have any interest in thinking of trying a single check at your hospital, please feel free to email me. And be glad to discuss it and how we could collaborate on this and get this. Again, we're going to need multiple centers, I think, to publish this. And there's a picture of me drinking wine. Some of you that know me, I'm a big wine connoisseur. And my boys, which hopefully one of them is going to go to Wisconsin. I would put a picture of my wife, but I think that's harder than getting approval from the IRB to get approval from my wife to put a picture in a talk. Have a great day.